Welcome to this episode of Orthodontics in Interview. It is my absolute pleasure to bring you MADHUR UPADHYAY. Thank you so much for joining me on this podcast.
It's a pleasure.
So I want to give the audience a bit of background about MADHUR because I have been following his work and using it in my podcasts and my lectures ever since I was a resident. So let me tell you about the contributions of MADHUR and where he is. So he is a full professor at the Dental School of Medicine at the University of Connecticut. He originally qualified from Manipal University based over in India, and he did his orthodontic certificate from the Department of Craniofacial Sciences at the University of Connecticut, where he is now the resident professor. He's done a master's in dental science, but key is his contributions to the orthodontic community. He is a diplomat for the American Board of Orthodontics. He sits on multiple editorial boards of all the big journals: AJODO, Angle, EJO, Progress, and the Indian Orthodontic Society as well. He has had 73 publications. He's authored 8 book chapters and also has a very interesting patent on AI in orthodontics, which we'll get into in today's podcast. So thank you, Madhu, for joining me. I'm really excited to have this conversation based around your contributions, looking at biomechanics, which is your field, and a field that you know so well and have published so eloquently on. I'm going to start off by getting into your guest editorial in bioengineering. This was published back in 2023. Now, I was really intrigued by your quotation in your editorial, and I'm going to share that with the audience. And that will set the scene for some of the questions I wish to explore with you. So, if I can just quote you, since Edward Angle first popularized the edgewise appliance at the turn of the century, orthodontics has primarily been driven by advances in appliance design. We have witnessed some rapid innovation in the past 2 decades with the advent of new technologies, materials, the appliances, innovation, often outside of orthodontics and base sciences, material design and imaging techniques, and other technologies such as AI, holding tremendous promise for advancing the efficiency of tooth movement. These developments have had a huge impact on the current standard of care, especially with adults, and will make for a treatment faster, accurate, and more in line with individual patient needs. I thought that was such a powerful statement to make. And the first question I'm going to ask you is perhaps why haven't we seen treatments getting that much quicker in terms of our appliances? So if we look at fixed appliances back in 2005, Joe did a publication showed average treatment is 90 months. Ali Kitishlaki in 2018 showed exactly the same. It's still 19 months from her systematic review. So although this is the idea and the concept that you've mentioned in your editorial, why hasn't it come to fruition? Why aren't we seeing treatments taking place quicker?
All right. Before I answer, Farouk, thank you so much for having me on your podcast. As we were talking, offline, that I have followed your podcast for a while now, and you bring in great insights
Thank you.
in a highly summarized manner for the current generation who doesn't have an attention span more than a jellyfish. So thank you for doing this, and thank you for the very generous introduction. When I hear that kind of introduction, I just get excited to hear myself. So
My pleasure.
appreciate all that.
Thank you so much.
Uh, Coming to the question that you posed. So if somebody goes back to that quotation, it was well thought out, basically emphasizing the fact that most of the advancements we have seen in appliance design has been through material sciences, biomaterials. And I purposefully did not mention the biological part um, of orthodontics because it is both amalgamation of biology and mechanics that drives tooth movement, and that's why it's biomechanics. However, biology has lacked in the past almost 100 years. In the sense, if you go back and review what has been at least one, and I'm going really down, just one. Can somebody just name one major advancement in the biological mechanism that drives tooth movement? Just one. And you will fall short of even one such major advancement. So, pretty much how Angle moved teeth through bone, let's say he moved the teeth at 0.5 millimeters per month, we are pretty much at the same rate, 0.5 millimeter per month. So biology hasn't changed. Um, However, yes, all of us are familiar with the advancements in design of appliances, from angle to bracket prescriptions through etching and bonding that came up. And of course, now we see, CAD CAM coming in and customized brackets and aligners and all that. So that's what I wanted to summarize through that statement. And going forward, you nicely quoted the literature saying that the fixed appliance treatment has pretty much stayed the same. And article after article reflects your statement um, as a pretty accurate statement. Um, Now, the thing is that, as I said before, there's biology and then there's material sciences, right? Material sciences help us in devising new appliances or new tools to drive that tooth movement. However, ultimately, the tooth has to move through the bone, right? That medium is not changing. So when a tooth drives through bone, although I'm not an expert in biological mechanisms of tooth movement, but from what I've gathered from colleagues and through the literature, it's an inflammatory process. That means there has to be first a damage, and that damage has to heal. So it's pretty much like bone repair. We are damaging the bone via the PDL, and then the bone got to heal. So if healing has not accelerated over the past 100 years, our wounds heal almost at the same rate as they were healing 100 years back, maybe 200 years back. So for us to expect that the rate of tooth movement is going to suddenly increase is pretty naive thinking. Like in general, I'm saying, because we need to see some new pill, medicine, something coming up in the broader market that tells us that, you know what, we have now accelerated healing process, or we have accelerated the bone turnover process or remodeling, something related to that. And then maybe we can expect to see, an accelerated or a higher tooth movement, rate of tooth movement. And people have tried it, right, to accelerate tooth movement. I believe it was in the early 2000s when I was kind of a upcoming resident slash orthodontist. There was a big impetus to accelerated tooth movement via, uh, you know, semi-surgical or surgical mechanisms like corticotomies, piezo-excision, distraction osteogenesis. And although it led to an accelerated tooth movement, but it also showed a lot of collateral damage in terms of sometimes root resorption, periodontal bone loss. So it comes at a cost um, to accelerate tooth movement. So, bottom line, um, I do not expect in the near term to even see an increase in the rate of tooth movement because um, the rate of healing stays is the same. It's not changing. I do not see in the medical literature something coming up that tells us that something's going to change in that area. So that will stay the same.
And also, Mada, in terms of aligners, we know that the improvement hasn't been significant. I mean, Kravitz study from 2009 showed 41% predictability movement. We have him then with his group repeating that in 2020, with Hawili as the author showing only 50% predictability. So we aren't getting better when it comes to orthodontics in terms of technology involved. And that's also with CAD/CAM. Can you explain that further?
An increase of barely 9% from 41 to 50%. As far as Invisalign goes, uh, I almost feel to expect more from Invisalign in terms of increasing, say, the rate of tooth movement. Now, with the backdrop of the healing part that I just described, it's like barking up, you're barking up the wrong ladder kind of thing. Because uh, the, the Invisalign material is again creating a force on the tooth, and the tooth will follow the inflammatory process. So Invisalign by itself won't be able to accelerate tooth movement. That's one. The second is the predictability part. Um, Invisalign hasn't changed its basic material. It's either PET PET or it's basically a bunch of polymers, and there are different variations that they're trying, but it's still polymer, right? So it's a viscoelastic material. That hasn't changed since inception, 1998 till date. So the basic material is the same. Um, so if the basic material stays the same, the stress or the force it puts on the tooth and the biological reaction it creates would stay the same, right? So to expect suddenly a big jump is naive thinking, and I can almost highlight this by the fact that from 2002 till 2024, there have been 10 generations of Invisalign smart attachments, the G4 attachments, G7 attachments, stuff like that. And I believe the study that you quoted by Kravitz 2009 came out or was done on the second or third generation aligners, like around that. And then from that point onwards to 2020, eight more generations, approximately, or seven more generations came in. And we only saw a 9% improvement. So all that pitching and marketing for every generation that, hey, there's a smart attachment, it's going to cause blah blah blah, hey, we have now G4 attachment, it's going to cause, didn't actually work out. So people got to go back to the drawing board and think what's going on. So what's going on is the basic material is still the same. It's like the iPhone hasn't changed a lot from iPhone 6 or 7 till now. I mean, the camera has changed, it has become very cool, we can take better selfies, but the phone is the phone, still the phone. You can still use your thumb to sign in or your face to sign in, and all those aspects haven't changed. So I kind of give that and as a good analogy to why Invisalign is kind of a static system for the past 15 years.
And that comes down to your editorial saying that the advances have been in the materials, but this is where the material is at this point in time. So if that's static, therefore there can't be any further advances. That's really interesting. So let me ask the question. Let me go into another field. Let's go into the biomechanics, because that is your world, Madha. And I'm sure there's a picture of you in the dictionary when this terminology is described. Now, what I wanted to get into was cantilevers, segmented arches, TAD segmental mechanics. These are complex biomechanical force systems, and I appreciate this is your expertise in describing how these fields work as an educator. But we find most practitioners don't use those in contemporary clinical practice. And my question to you is: as much as we all agree on the principles behind this, why isn't it happening regularly in routine clinical practice?
Yeah, that's a very pertinent question. And that question I almost pose to every group of listeners or residents or students when I go to lecture. And it's interesting you asked me the question because I just wrote a paper for seminars in orthodontics that should be coming out or might be out already upon the first principles of biomechanics. Um, it kind of touches upon your question. Um, Actually, I would say it does touch upon your question in detail as to why uh, regular practitioners, and in regular I'll put myself also in that bucket because I also practice orthodontics and I see a bunch of patients, and I would admit I do not use, for example, a lot of TADs, right? I do not use a lot of surgical based approaches to move teeth. Okay, I'm pretty much doing the regular orthodontics that probably you or somebody else in a small town in some country is doing. And actually, the answer is pretty straightforward, which kind of follows in general how humanity has progressed, right? Um, we will always adopt the path of least resistance if we arrive at the same result. So, if there are three different techniques that at the end of the day give you the same result, you will automatically move towards the simplest approach. So, for example, talking of TADs, if suppose you're using TADs in your practice, let's pick a simple example for anchorage because that's the most obvious use case. and you are doing a bunch of extractions, as some of us at least do 20 to 30% of our patients with extractions, and you're controlling your anchorage just by putting tabs, right? And on the other hand, you have a bunch of patients where you're not using TADs because they either refuse TADs or they could not pay for it, whatever be the reason, and you're using some other mechanism of reinforcing anchorage. It can be anything. It can be, I don't know, headgear, class 2 elastics, whatever people prefer. And you are seeing again and again that, hey, I arrive at the same result, class 1 molar, class 1 canine, class 1 molar, class 1 canine in either of the situations. You start literally questioning yourself, for sure subconsciously questioning yourselves without even realizing that why am I using TADs if I'm getting the same output. So in your practice, TADs starts dying away to the extent that you don't end up using it at all because now you've perfected that other method, whatever that might be, to gain good anchorage. So that's what has uh, played out in these, I would say, more exotic ways of treatment, and we have automatically gone towards the regular way. However, as again, offline we were talking about, but we see when we go to social media or when we go to meetings, we see, however, TADs, like we see all these stuff that I would say is on the fringes of orthodontics, and we come out with the assumption that this is mainstream orthodontics. However, it is not. If we reflect in our own practices, because these are sometimes used as a tool to get more clicks maybe on social media, to gain more attention. Because hey, if I start talking with you about class 2 correction with class 2 elastics, people will turn off their phones immediately because they would be like, I do it all the time, like this is nothing new I'm hearing. So uh, the exotic things catch your eye, and we start thinking that that is what regular orthodontics is, but it is not. um, And there's a second part to a question, that why is not cantilevers or segmented art mechanics? Well, as I said, this is a lot of stuff to pull together in one question because everything has its own answer. Segmented arch did not work because it is very tough to gain three-dimensional control over the tooth if you're using just a loop in a segmented way, because the tooth moves in three dimensions. You can control the tooth maybe in the AP direction. For example, if somebody is retracting the canine off a loop, however, the canine is going to spin, rotate, tip, do all those things. And in the literature, in the clinical literature, there has not been convincing evidence to support that you could gain good control via segmented approach. There are in vitro studies, granted. There have been benchtop studies, granted, but not clinical mainstream studies that have repeatedly shown that you gain good control over tooth movement with a segmented approach. It's in fact extremely tough. Any of us who have tried it on a repeated basis will automatically come to the conclusion. So it has not worked. What has worked is maybe the hybrid. Like you have a regular mechanics going on, like our straight wire sliding mechanics, and somebody piggybacks something on it. Like we do a lot of cantilever on top of regular mechanics. Like you have a regular wire and you put a cantilever on top of it to, gain certain functions out of it. So that's where, again, natural progression has been from a segmented. Now everybody's on a sliding mechanics, because it's the path of least resistance and it's giving you the same results.
Amazing. That's what I wanted to know. That's what I want to know from Ada. We see the theory, we agree to the theory, but we don't implement it much often. And that is an excellent understanding.
And I think for there's also something more to it. And maybe you were going to touch upon it later, but maybe this is a good time for me to just chime in with that. Like, you know, uh, in orthodontics, we study diagnosis, we go through biomechanics, and then we go to, various techniques of treating. If you, I- the area that would take probably the maximum amount of effort to grasp it is mechanics or biomechanics, because it does involve just not rote reading, but understanding of a little bit of physics, you know. And that is like, you can almost call it like a moat or a stumbling block, like which doesn't come easy. For example, if I want to know how to use a fixed functional appliance, I would read a 3-page article or listen to a podcast or something, or watch a video describing how to insert a fixed functional appliance, and I'm off the races. I can start using it in my practice, no problem. But if you follow the same path for understanding biomechanics, that I read these 5 pages and I'm a master in applying the basic principle of biomechanics, that's not going to happen. It needs concentrated effort to learn it, which which in itself is like a moat. It 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 creates that divide where some people can cross that bridge and understand biomechanics, and some give up because it does involve a lot of effort. But unfortunately, or I don't know how to put it, it is the foundational basis of how everything is done, like the basic mechanical principles. So I think that's why, this is one of the other reasons why cantilevers, or say some bends, putting a lot of bends in the wire to carry out specific movement, is not widely adopted, because everybody knows how to put a bend. Like, you take a plier, put a bend, it takes 2 seconds. But when to put it, how much to put it, and most importantly, where to put it between two brackets, that knowledge requires a lot of repeated reading, understanding, maybe attending a few courses, I don't know, whichever way you want to consume that knowledge. So that's an ongoing process of honing your skills on biomechanics. No wonder at UConn I conduct almost a 40-hour course on biomechanics 1, and then an 80 to 120 hours course on biomechanics 2, and it takes up majority of my time there. So yeah, that's an elaborate answer to a one-line question.
No, but it was great. It gave us wonderful insight into it. And it's that kind of concept. You can get 80% of the way there with 20% of the effort. But to get the last 20%, you have to put 80% effort in. And ultimately, it is the foundations of our science. Okay, Mada, prescriptions in fixed appliances. Um, which prescription do you use? And do you think those prescriptions have aided our development and understanding in terms of clinical practice, or have they actually stopped us thinking more about individualizing treatments for our patients? And ironically, as great as they have been in terms of clinical practice, have they now withheld our individualization, as you mentioned in your editorial?
Having pre-adjusted edgewise appliance, what Andrews did many many years ago, and which was followed up beautifully by Roth, and then further improved by Bennett McLaughlin and Trevisi in the 1980s, is perhaps the last major landmark progress in fixed appliance and in orthodontics. If you follow our literature after that, once pre-adjusted edgewise appliances were introduced, there has not been a major innovation in either fixed or removable appliances, and that covers aligner. Because aligners were, if you can recall, aligners were there even before it was commercialized in 1998 by a startup company in California. Um, so yes, pre-adjusted edgewise appliance was a major, major leap, because previous to that, orthodontics involved a lot of wire bending because it was standard edgewise. So two major shifts helped us a great deal. One was introduction of etching, which helped us bond brackets, because previous to that, life was tough. You have to band every tooth. And then simultaneously around that time, the pre-adjusted edgewise appliance started taking over. Um, what it did was that a lot of the in-out bends, second order bends that we had to place, or not we, I should say, but the orthodontists in that era had to place, was just taken off. You didn't have to do that. Now you could concentrate on the finer aspects. So potentially it was a gateway for us to further enhance our finishing in orthodontics. And I think there was an era, I believe, from the late 80s, 90s till the early 2000s, uh, when finishing greatly improved, and there were some beautiful papers and articles written on how to finish, and ABO came up with this beautiful standard of how to finish patients, and I'm sure other boards also came up with their own standards, and they were like keys to finishing. I remember still reading papers, 16 keys to finishing, and there were textbooks on finish. Like there was, and they described how to finish with a pre-adjusted edgewise appliance. So I think that was great, till of course the advent of aligners, when we were not we are not able to achieve all that that fixed appliances can achieve. So forget achieving those minute finishing steps with aligners that can truly mimic what fixed appliances or pre-adjusted appliances can do, and that started diluting the emphasis on accurate finishing. uh, so uh, I don't think pre-adjusted edgewise has taken away anything. Now it's up to the clinician how much deeper they want to go, because you already have a set look of the teeth when you're finishing a case. And now, do you want to go ahead and even fix that zero point 0.5 millimeter marginal ridge discrepancy, or that 2-degree less mesial tip on your patient's canine? So I think pre-adjusted edgewise appliance is a great, great, great addition in the world of orthodontics.
And I have to ask you, which prescription do you use,
Oh
madam?
yeah, we missed that. Um, so I have, of course, in the initial part of my career, used a lot of Roth prescription, but now it's more of MBT, not due to any specific reason, but um, just because of its primarily because of its higher torque for the upper incisors and the beautiful mesial tip on the canine. I like that aspect of it. But I'm very flexible in terms of changing the prescription based on the patient need. Not that I'm changing the prescription, but you can manipulate your brackets, like by turning it upside down, switching left to right. You can have a lot of customization automatically for your patients.
So I'm going to come back to the aligners, as you've mentioned, in terms of the lack of material to be able to deliver those movements. And I really want to explore this with you. What we understand is that the material loses a lot of its initial force through the process of stress relaxation. And that's quite remarkable looking at the literature, actually, preparing for this interview. Within 24 hours, we can get up to a 54% loss of that initial force levels. And this seems to come down to the concept of creep. The material seems to be getting larger in that period of time. Now, that remarkably affects the moment to force ratio in terms of starting off with something which would be ideal and favorable in terms of biomechanics, but actually rapidly kind of takes us away from being able to control, get it to 16 to 1 and going from 12, and actually gets us below that kind of 4 to 5 threshold where we are now just looking at tipping. My question to you is it fallacy that aligners can move the roots of teeth and achieve translation? What's your interpretation of this variation within the appliance itself during its use?
I'll start with a comment that you made a while ago regarding aligners itself, saying that there has been documentation where people have seen root movement when they are moving, the crown, and they see the root move. So root is moving, right? Um, yes, it is. To say root is moving. However, the root is not moving according to the wish of the orthodontist. Let's put it that way. And that goes down to a simple definition of tooth movement in biomechanics, which says that imagine you apply a force on a freestanding tooth, and there is only a force on the tooth. Forget the device, forget the appliance, just a force vector going on the crown of a tooth. If you do that, what is the tooth movement you would see, or what is the type of tooth movement you're going to see? Will it be translation? Most likely not. Will it be like roots moving? So the movement that you get when you just apply a force on the crown of, say, a central incisor is defined as uncontrolled tipping. That's the basic definition of uncontrolled tipping. What happens in that is the crown goes one way and the root moves slightly the other way, with the center of rotation slightly above its center of mass or center of resistance. This experiment can easily be done by giving a Holly to a patient trimming of the acrylic from the lingual and activating the Holly. You can recreate this single force on a crown. And by the way, this experiment has been done with a Holly clinically to show uncontrolled tipping. So it's properly documented. Now, in this particular movement, the orthodontist did move the root, but probably he, she, or they did not want to move the root. It was just a byproduct of the force application at the crown. This is the easiest movement to execute, and we get this movement in the first stage of orthodontics when we have night high wires going through a crowded dentition. The teeth are freely tipping, most likely in an uncontrolled manner, crown going one way and the root going the other way, albeit not in equal quantity, but the basic motion is that way. Now, what happened in the aligner literature that some clinical research that was done with aligners saw this root movement, and they documented fairly enough, they had to document that we gave aligners and the root did move this much millimeters. But that was an accidental movement, not intended. The way we imagine root movement in orthodontics is sometimes miscoded as torquing. It's a misnomer. Torque is a physics term that says it's a rotational moment, or it's a moment based or a rotational movement. When created, it's done by a torquing. So, what happens in orthodontics when we say torquing? We mean to say, I do not want to move my crown. I only want to move my root. That is what most orthodontists mean when they say torque. That this particular movement, where the crown is not moving, or in other words, as we define it in biomechanics, we say that the center of rotation is at the crown or the bracket. This is called torquing, and this movement has not yet been properly documented in the Invisalign literature. Like nobody has successively shown in, say, 15 or 20 consecutive patients clinically that they were able to create this kind of movement in a predictable manner. And I believe there have been now at least 6 to 7 papers on space closure, like good papers I'm talking. I'm sure with the crazy literature, there are so many papers coming every day, but probably the top 8 journals, let's put it that way, that have shown again and again that root movement is not happening in a controlled manner. So it's just a tooth freely moving through the bone with very less control over the root.
I think that's really interesting because when we read the literature, at least superficially, it would look as though the aligners do move the roots of teeth because it does show movement taking place. But the question was that planned movement? And I think it was Fan Day study. We looked at extractions in 2018 and with aligners and showed roots did move, but actually it was meso movement of the first molars, which was not planned. It wasn't intended. And of course, you've got the systematic review that you've been involved with, Sarah Al-Alqub, which looking at extractions and aligners. So congratulations on that paper. It was an excellent contribution to the literature. I just want to ask a question about: is it the now the we still hear from aligner companies the focus being on better software, better attachments? In this conversation, you've highlighted that it's fundamentally a material property, which is the bottleneck. Is that something that you think software can resolve, or are we just barking up the wrong tree, as you mentioned? And actually, this is it. This is where it gets to.
I think you're correct by the latter part of your statement. Yeah, we're just barking up the wrong tree because uh, all the software innovation is on the periphery. Like it is making probably the life of an orthodontist easy, or their assistants easy, because now they don't have to take alginate impressions. They can just scan. um, they don't have to pour out stone models and make retainers. They can do everything 3D. So it is streamlining that part of orthodontics. But whenever it will come to actual tooth movement, it's basically the material that is applying a force on the tooth. So in Invisalign, it's a polymer that is applying you know force on the tooth. With fixed appliances, it is a wire and rubber. applying a force on the tooth via brackets. So that literally is the first principle from a materials point of view for tooth movement. Anything that's happening in the technology field will just ease the life of an orthodontist in terms of the extra work that we have to sometimes do, as I highlighted, taking impressions or taking pictures, uploading pictures, a diagnosis, sitting in front of the screen and diagnosing a patient. Technology will have a huge impact in that area, and that is where all the innovation is happening, be it light force orthodontics, or be it all the latest software upgrades that Invisalign gives. It's like a new interface, you can plan this way, all those things are just making the let us call the mundane work that comes with orthodontics easier. But nothing has happened fundamentally with the way we are moving teeth, or let's say the rate of tooth movement.
So let me touch on your patent, actually looking at AI, and it's okay for you to tell us a little bit about it. So you've had your patent looking at decision making models for orthodontic diagnosis and treatment planning. So just on this topic that we are describing,
Mhm.
can you tell us some more about that? How do you see that integrating into clinical practice? And I've got a question to ask you. Do you think that will take the knowledge base of orthodontists essentially away from them? We don't need to now consider where the center of resistance and rotation is for those individual movements, because actually the software is now developing. Do you see that taking away some of our science and putting it onto?
Yeah, so regarding the patent, it is a patent to basically integrate artificial intelligence, or machine learning and deep uh, learning more specifically, to streamline diagnosis as well as treatment planning. Um, what we did was, instead of relying on just one mechanism of streamlining diagnosis and treatment planning, we have incorporated three or different mechanisms, which are sub branches of machine learning and deep learning, to arrive. So it's almost like saying you have three AI agents working simultaneously on your patients to come up with a diagnosis. Each one of them will come up with their own diagnosis. Then there'll be a fourth AI agent within that algorithm that's going to kind of analyze all the three outputs and then come up with the final output. So it's like multiple layers of evaluation to come up with as accurate a diagnosis as possible. So that's why we got it patented, because at that point we thought that it's a unique approach. And this was way back in 2019 or 20, something around that time. But then we had this big wave of, AI, let's call it resurgence, because it was a big thing in the early 2000s, and then it kind of laid quiet, and then suddenly now it has come in a big way, where now uh, I think this has become the norm for many companies to have multiple AI agents to work on a particular problem, and then they arrive at a consensus, which is a very obvious thing to do in hindsight. So in many terms, the patent is there, but it's kind of, AI is changing so fast that much better things are popping up. And we are kind of working on it. We are currently working on a user interface, so we have the algorithms ready, and we are working on the user interface. It's a tiny step towards automating almost everything in diagnosis as far as we can do. Um, so hopefully in the near future we'll get to see more of it in people's hands, and maybe I'll give you a link to test trial it, and give me the feedback as to how it's actually doing for you in your practice.
Yeah,
Um,
anything that takes me beyond being the below average orthodontist would be very much appreciated.
mhm.
Um, do you think this will take us
Yeah.
away from further away from those first principles because we're no longer having to apply them as much? Do you fear that it will be the screen and the software making the decisions, and we will just be the outputs of it?
I think the process has already started. It already started 30, 40, 50 years back, when, going back to the question of pre-adjusted edgewise appliance, when a whole new generation of orthodontists was not required to place first order bends when they started a patient. They could just freely place brackets, put a regular wire. Uh, this was further amplified by the uh, by the innovation on night high wires, when they were brought in. There were no stainless steel wires anymore in the initial stage. You didn't have to bend those crazy loops in wires to give it flexibility to align teeth. You could just throw in a night high wire. It started with it was further pushed by etching. You didn't have to band everything, and you could just etch and put bracket. It was further accelerated by pre-adjusted edge wires, which we discussed, where everything was built into the bracket. So with AI now, even the not only the mechanical part, but now even the thinking part is being taken away slowly. We already have stepped into that with, where us orthodontists, we rely on various softwares to do our to give us some kind of analysis on our cephalogram, be it dolphin or whatever you're using, where you just put the points and out comes the analysis, and we literally follow the norms that are given on a dolphin output of ceph analysis. We don't even question if the norms apply to my population, does not apply. We just go by that, to the extent that people have forgotten that the so-called ideal angle for IMPA in Tweed's analysis is actually 90 degrees. And the 65 degrees, which is the FMI, is the key metric you have to consider, and then optimize your lower incisor angulation based on that. We just go by a 95-degree norm that somehow Dolphin gives us, and we assume 95 degrees is what Tweed proposed, but that's wrong. There's no emphasis on FMI on those software, so we don't even understand the concept that why are we doing this IMP. I'm just giving us, kind of a side example of that. So we are already on that path, and AI is going to take us further away from going into the details, of course, because a machine is doing it for you. And you might have experienced that with all the LLM models being floated around, including Claude and Grok and, OpenAI and ChatGPT and stuff, where people are saying, hey, plan my vacation on AI, and AI does a pretty good job, I must admit, of planning a vacation. So we have started to offload, and it's naive to think that that won't affect orthodontics. It will. And by the way, to touch on that, we have already offloaded our thinking by using a lot of Invisalign, where a clincher comes in, and many of us just go yes, 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 yes to all the recommendation, little we know that most of those uh, treatment plans proposed is maybe by a technician sitting somewhere in a country nobody knows, and you're just accepting that plan by clicking yes, 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 and of course by some algorithms. So technician plus algorithm setting a plan for you, you just say yes, and you move on.
Trying to refute it. In terms of biomechanics, can I ask, as an educator in this field and an author within it, what do you find are concepts that are most frequently misunderstood in terms of biomechanics that you find that clinicians will stumble on repeatedly, both for fixed appliances and aligners? What do you see those as?
Well, again, like, it's a good question, but yes, there can be many answers to this, because there are, frankly speaking, a lot of aspects. Uh, to put it, one answer can come from a very basic aspect of orthodontics, like very basic of biomechanics, is getting confused between center of resistance and center of rotation. We often intermix both these terminologies, where center of resistance is something we cannot do anything about it as orthodontists. Center of resistance is there, it's there, we cannot change it, we cannot modify it. Center of rotation is something that only an orthodontist can change and modify it. Center of resistance is fixed on a tooth, as I said. Center of rotation can have infinite number of locations depending on your mechanics or what you want to do. So, just to put a nutshell, it can be as basic as that. But I think in a broader context, um, one of the biggest things that I would love people to understand more is friction. Friction comes with a very negative connotation to it, that friction is bad. I want to eliminate friction. I want to have self ligating brackets. While the reality is just the opposite. Friction is awesome. Friction is great. It's great we have friction, because we would be miserable if there was no friction. And I'll try to just, by putting two sentences, I hope I can put the point across. Whenever we move teeth, Barring the initial leveling aligning, after that, whatever happens, at a time, we are only moving one, two, or three teeth, like be it canine retraction or incisor retraction or molar protraction or intrusion of few teeth. Most of the times, we do not want the other teeth to move. And the only thing that is basically preventing its free movement is fine resistance from the bone, but the friction that you're generating. And because that friction part was taken away in segmental mechanics, there was uncontrolled movement everywhere. So, yeah, friction is awesome. And as far as, something that is, I would say, almost a big misconception in orthodontics is we are taught this way in our head, it has been ingrained this particular phrase: light, continuous force. When the reality is, none of us use light, continuous force. And it goes further deeper that light, continuous force will create more problems than good. And it's a much, sorry, what? Um, yeah, it is. Titanium wire is light forces, and that's why with titanium wires or nickel titanium wires, you can only level a line, which is basically uncontrolled movement of teeth. The moment you say, hey, I want to gain some root control, you need higher forces. Or when we do expansion, I mean, if I'm right, and people can go to the literature and look it up, every turn creates, and people don't have no clue, creates forces anywhere from 20,000 to 30,000 grams. That's 20 kgs to 30 kgs in English system of not pounds. That's why I'm going to kilograms. That's crazy. You are literally exploding dynamites in the palate whenever you turn. Imagine the bone, imagine the necrosis that's following that. And as I said, it's pretty much clear in the literature out there the amount of force that is being generated, but we still do it. Or when we do headgear, or when we do fixed functional, or when we do, we're all the time using heavy forces. The other way, so that's with heavy. Why continuous force is we don't use that either? Well, there's a popular phrase, right, in orthodontics: walking off the tooth, walking off the canine. What it tells you is that the tooth tips and then uprights and tips and then uprights. So if you want tipping and uprighting to happen, your force should go up and down, up and down, up and down, and not stay continuous. And as I said, this concept I go slightly deeper into the biomechanics courses where I can, more elaborately exactly pinpoint why, it is always intermittent forces that are beneficial. And the biggest example in front of us, again, all of us are using aligners. It's intermittent forces galore. There's nothing continuous about it at all.
You're absolutely right. You're absolutely right. But we all say it though. I'm guilty. Okay, Mada. Could talk to you all day. I've really enjoyed this conversation and the insight that you've given. And guys, at the end of this podcast, there'll be a list of the most recent studies carried out by MADHUR. The one that I'm the biggest fan of is its Aligner Biomechanics, the hidden truths in the JWFO. That for me was one of the most formative papers I've had in understanding how clear aligner therapy works. So thank you very much for that, and your co-partner Sarah Abu Argub. Mada, just to conclude today's interview, can I ask what one piece of advice you'd give to the orthodontists who are listening to this podcast from yourself?
In my little experience and what I've learned over the years, through my travels and teaching and clinical practice and research, by the way, I would say that what I've learned is that orthodontics is basically has these two big blocks. It consists of two big blocks. It is diagnosis, got to be very good at that, and biomechanics. If you have a grip on these two, you will be like probably one of the best orthodontists out there. And I myself am striving to get a full grip on this, so I'm nowhere there. And the interesting thing is they work on a feedback mechanism. What I mean by that is, suppose you're an orthodontist who is not comfortable doing extraction patients because maybe you lose anchorage or you're not able to control teeth and you just hate the liability that comes with it. your diagnosis will automatically shift towards more non-extraction. You will tend to feel comfortable with all non-extraction approaches. You'll tend to popularize those approaches. You'll try to find ways and means to showcase that, you know what, non-extraction works great, which probably what happened to Angle or to other, I don't know, I'm just kind of saying. Tweed got comfortable with extraction, so, or he saw good results, so he, kind of pushed that agenda. So that's something that I would say that please try to master these two areas. Of course, I know it's biased, but I would say biomechanics is key. But you should understand that the biasness does not come from a self-interest, because nobody can patent biomechanics. Nobody can patent Newton's laws of motion. That boat has long sailed. So I'm not coming with a marketing pitch or agenda, but I'm saying if truly somebody wants to get a grip of orthodontics, biomechanics is the key. I would like to also, because you have a pretty good platform, Farouk, um, sign off by asking people to explore more into the aligner field on the side that is not that not that well known right now. That aligners comes with an additional baggage of microplastic contamination in your blood. That is something that the literature has started to deal with in the past few years. And microplastics in the general literature has been shown to be a problem. So, whatever material we are using, if it generates a lot of microplastics in our bloodstream, it is a problem. It is not to be confused with cytotoxicity. That's totally different. That's the chemical reaction they ignite, but this is physical presence of particles in the bloodstream. And more importantly, since 2019 or 20, with the invention of Raman spectroscopy by University of Columbia, they've gone deeper and said that actually microplastics is just the the top layer. If you go deeper, nanoplastics, which are particles in the order of 10 to the power minus 6 millimeters in size, those are the bigger problems, because they can freely cross any barriers, physiological barriers of our body, like the blood brain barrier. They can even go freely across the cell membrane, so they can start interfering with the genetic material past the nuclear membrane. And that has been heavily researched into, and the initial reports have not been great, linking it to various kind of diseases and stuff. And we are in a profession where we are giving these plastics to our patient and actually pushing them to wear it 22 hours a day. And some of our patients are even eating or drinking with it, I don't know. And we use them as retainers. So I don't know. In one world I live where people are shying away from plastic, where they hate to drink from plastic bottles, they hate to use plastic stuff. So I'm living in that world, and I'm trying to follow some of those things in my regular life. But then I come to my clinic and I see a bunch of plastics being given in the patient's mouth. So I'm at a very ethical dilemma, frankly speaking, at this point of time. So this is a message I just wanted to give. I don't want to mean to pontificate and to tell somebody to go this way or that way, but just to explore this area a little bit on your own and decide for yourself what you want to do.
Amazing. Thank you so much, Madam. I think I need to get you back. I think in 6 months, a year's time, we have some more literature on this topic. I think we need to delve into this. We should shine the light on this as we understand it. Madam, thank you so much for your time. And as always, please do subscribe and look forward to the next episode. Thank you so much, Madam.
Thank you for having me, Farouk. Take care.